Thank you, Dr. Sally. Hello, everyone. Happy to join the study club at the Tooth Corner and become a member here. Hope everyone had a great day and get prepared for a relaxing night and listening to some endo. So today's topic is going to be about cleaning and shaping the apical third of the root. So cleaning and shaping the apical third of the root is very essential to the clinical success of the endo treatment. Apical third is actually one of the most difficult aspects of the roots in cleaning and shaping because of its complex anatomy. And the complex anatomy is basically the ramification, which is the branching or the accessory canals, or the tortuosities, which are the curvature of the roots, which make it difficult for cleaning and shaping. So just to review on some clinical apical anatomy, I'm sure you guys are familiar with all of these terms, but I'm just going to quickly go over them. The apical terminus is essentially the end of the main root. Root apex is the vertex of the root. Some main canals or accessory canals may or may not exit at this point. Sometimes they may exit at the side. The cemento-dentinal junction meets at the apical portion of the root. It can be inside, just as you see in this image, more internal, but it could also be outside on the surface of the roots. It is not really clinically significant in terms of cleaning and shaping. They typically think that apical to the CDJ is the PDL and coronal to it is the pulp. The foramen is the opening of the canal, where the canal is believed to be a funnel shape and open at the foramen. Apical constriction is the narrowest aspect of the apical region. Most people cleaning shape to this level, which is 0.5 to 1.5 millimeter of the radiographic apex. And the radiographic terminus is the end of the canal, which is shown on the radiograph. And because sometimes we get a buccal or lingual curvature of the root apex, it doesn't always necessarily mean that if we see the file all the way to the radiographic terminal, it doesn't necessarily mean that it's clinically also at the most apical aspect due to that buccal lingual curvature of the apical tip. Ports of the exit is multiple openings of root canal on the root surface. The main canals or the accessory canals. So cleaning and shaping is actually the most important part of endodontic treatment. Cleaning refers to the removal of organic substrates such as bacteria, pulp remnants, body fluids, and food debris. Shaping is creating a canal into a continuous taper for effective obturation or filling of the gutta-perca cone. Shaping does also assist in cleaning as well. It's easier to clean a larger canal than a narrower canal. And there are also many objectives in cleaning and shaping. The objectives are for cleaning and shaping are to have a continuous tapered canal, to create a narrower apical aspect than a coronal aspect in a cross-sectional view. Cleaning and shaping also the objective is to maintain a flow in different planes, maintain the original location of the apical foramen in relationship to where the root surface is and where the bone, and to not transport the actual foramen during cleaning and shaping, and keep the apical foramen as small as practically possible. There are 10 commandments of cleaning and shaping. Each one of these, we tend to try to follow these 10 commandments as much as possible. Following them based on their correct technique is the ideal. I know it cannot always happen, but our goal is to be as close as possible to these techniques in order to increase the rate and the chance of endodontic treatment success as high as possible. So the first technique is the probing, which is essentially we use a first instrument, which is usually a 10K file, and it's held gently and freely with our thumb and with our finger at the handle area. This allows a good length of the file to be placed into the canal, and it magnifies our tactile sensation. The sharp tip is used to go through the collagen fibers or the fibrous barriers that are in the file. It's important to note that we shouldn't apply too much force on the file because it could act as a bulldozer and cause blockage from the dentinal debris, or it could even create ledge or lead to breakage of the file. The apical portion of the canal is where most of the pulp ramifications or the branching are located, and the turns um, or the curvatures. And it is more firm and more fibrous tissues located in the apical third of the canal. So it's very important to have a high tactile sensation and be very careful while we're probing the apical third of the canal. Carving back is the second technique we use. So a file is essentially has a tip and an elbow. The elbow has activated flutes, which cuts the dentin. The carving back technique is the rotation and translational withdrawing action of a pre-curved file against the dentinal walls. This brings the dentinal debris out after obviously irrigating it, and it essentially pre-flares to avoid issues such as transportation of the foramen, blockage, incorrect path, which could lead to perforation. Pre-curving is something we're all familiar to, especially with molders, which have a curved canal, and we want to adapt it to the curvature of the canal. So pre-curving of the file, the magnitude of the curvature should always be greater than the actual length of the canal. Smaller files, such as the 10, 15, or the 20K file, should be pre-curved closer to the tip, which creates a smaller elbow. This is great for creating a probing antenna and locating and having achieving proper apical patency. Larger files like the 30, 35, 40, and beyond, um, they're typically pre-curved further away from the tip, and that creates a larger elbow. This is because it tends to be stronger and more effective in cutting dentin in the larger canal circumferences, so more the coronal aspect. The fine file bounces back. So bouncing is pretty much when a fine file bounces back when it's encountered by a resistant or a barrier. This is properly done. The bounce back phenomenon occurs if you allow the canal guide the instrument as opposed to guiding the instrument through the canal. So we always have to kind of passively enter the canal and not enter the canal with any force, because again, that could cause the breakage and creation of ledge. So always let the canal take the instrument down. Serial sequencing is another point of that 10 crucial points. It is essentially the filing and reaming in a sequence manner in the canal in order to enlarge the canal from small to large files. And this enlarges the canal evenly and smoothens the wall without creating steps or ledge. A lot of these techniques have many overlaps, but the concept is slightly different. So again, filing it in a sequence from small to large to enlarge it evenly and smoothly without creating steps. So recapitulation is also another term where most of us are, like all of us are familiar with. It is the repeated reintroduction and reapplication of previous instrument used through cleaning and shaping, previous smaller instruments after we've used larger ones. This is to create a well-designed, smooth and unclogged, and an evenly tapered or unstepped, unledged root canal prep. After a few recapitulations, the files tend to advance deeper and deeper near where the apical end is, with better patency and better flow. The envelope of motion is the up and down stroke or the push and pull motion of a pre-curved file with around an amplitude of 0.5 mil to 2 millimeters. It is accompanied by a rotational clockwise direction when we're taking the file out. This should have definitely include the rotational motion as well as the push and pull. And it should cover the circumference of the canal wall and the entire length. This is used to establish apical patency. This is actually one of the most important techniques in establishing proper apical patency. And smaller files such as the 10, 15, or 20 are typically used to go beyond the curvature. The bigger files are more for straight canals or the straight aspect of the curved canal. Irrigation is, again, one of the most important steps in the cleaning and shaping. Copious irrigation should happen with 2.5% of sodium hypochlorite. We should have at least 30 milliliters of sodium hypochlorite for each canal after each instrumentation. We use a 22 gauge needle, so it could easily fit in the canal. It's not going to go all the way down, but it's going to be comfortable fitting in the canal. We do the irrigation to prevent any tooth discoloration. It is a bleach solution. It does digest necrotic organic debris, and it also acts as a lubricant due to its low surfactant properties. It is also a potent antimicrobial agent against bacteria, fungi, and viruses. It can be a little bit toxic for the human tissue, but it's not too toxic for the tissue, for the bone or the PDL. So it is important to not inject the sodium hypochlorite solution, but rather eject it and withdraw once we're applying the solution. Serial filing and the use of sodium hypochlorite really increases the success rate of the endo treatments. I would recommend to continuously irrigate between each step, because sometimes when we don't obturate certain accessory canals or apical portions, having the proper irrigation definitely avoids any reinfection. And also for the irrigation, after irrigating, it's great to use a smaller file, the recapitulation technique, to push those irrigation solution, not apically, but rather into accessory canals. Peaking is using a number 10 file, which peeks through the root surface and just barely reaches, shakes hands with the PDL. It doesn't necessarily mean it's extruding, it's not being over-instrumented, it's reaching the radiographic or the clinical apex. The radiographic terminus may not always be beyond the root vertex of the root surface. Again, this is mentioned due to its variation of the geographic position of the foramen, because it may be a curved buccal or lingual, or the main canal might just naturally be positioned in the lateral aspect of the roots. If a canal is not blocked or stopped with dentin debris, ideally the root canal filling should end at the root surface or the most apical aspect just before touching the PDL. But a lot of times when there's, and clinically when there's cleaning and shaping happening, we get some level of debris at the apical end, which prevents our root canal filling to enter all the way to the apical aspect. Again, this is ideal. It doesn't always happen. We try to be as close as possible to the ideal. And lastly, hunting for the accessory canals. This seems a little bit hard. It does require a lot of patience and experience. But this is usually done with number 10 pre-curved file. After the canal is clean and shaped, it's recapitulated, the accessory canals can be found before we do the gutta perca fitting. It's easier to find it if the main canal is scrubbed and smoothed. So each one of these previous steps that we described are very important for this last step of hunting for the accessory canals. Just as I mentioned, a number 10 pre-curved file is used. A small curve, a 90-degree curve, is applied to the near the tip. And we gently try to find the accessory canals and hand file it until we could create it larger, where the irrigation solution could go, and where the sealer or the gutta perca could enter to prevent any reinfection or leakage in the root canal system. Many of the times, like large, if the accessory canals are large, they could actually be cleaned up to number 20 files. So in summary, we've talked about the importance of cleaning, shaping of the apical third of the root canal. It is the hardest because of the complexity of the anatomy. We discussed about the importance of knowing each apical anatomy, knowing the clinical apical anatomy and the mechanical objectives of cleaning shaping, and we discussed the 10 commencements of cleaning shaping, which we want to reach that ideal stage, although we're trying to be as close as possible to increase the success of our root canal treatment. Thank you very much for listening. Any questions or concerns, we could proceed.
Thank you so much, Dr. Baghani. That was a very nice summary of the article, and it kind of forces us to read the article and listen, because I'm sure we're all busy and sometimes it's tough to find time to read a 5-page article. So that's why that's another reason for having these bi-weekly discussions. It's just for us to take some time to review these key topics in dentistry. Dr. Lewis has joined us, and I'm very grateful for that because it was a last-minute request from me. What do you think? Shall we go ahead with a 10-question poll first and then open the floor for questions? Or shall we have the questions first?
I'm good either way, whichever you're comfortable.
Maybe we'll do the poll first.
Sure.
I see that it is in progress, but I'm not too sure if you guys can see it and can vote. Montez, can you check? Or Fatma, can you check if you're receiving any votes?
Yes, we are receiving votes. There are 7 out of 22 right now.
Excellent, excellent. Montez, there are questions from Dr. Fida and Dr. Sandra in the chat. I'm not too technical.
Okay. Should I end the vote and have people try again?
Did you guys just launch the poll? Maybe when you did it, did you choose relaunch or?
Oh, it needs to be ended and relaunched. No. Yes,
Yeah,
Fatma?
end it and relaunch it.
Yeah. Okay. Good.
Try that again. Yeah, you got it.
If everyone can, or a few of you can confirm that they can see the poll.
I like it popped up into my screen, but I'm a co-host,
Okay.
so,
Perfect. I see one thumbs up
okay.
from Dr. Osman.
Can you see the results of the poll? Whoever's got it up on their screen, Motaz or Dr. Ehsan, can you see the results showing?
Like it says 0 out of 22. So.
No results in yet.
Okay, but as soon as somebody submits after the 10, you'll start to see them, and you'll start to see them like add up pretty quickly.
Yeah, yeah. Let's see the results coming through. We have 10 out of 22 participants who submitted so far.
How are we doing, Martez?
We are at 63%, so 14 out of 22. 68. I think we can wait maybe 3 more minutes, and then we can end the poll.
Sure, sounds good. Meanwhile, if any of you, for those who submitted already, if you have any questions, you can type it in the chat.
I think that's everybody because Mutaz, myself, and Ehsan are on here. So that would be 22.
Okay, excellent. So shall we take up the poll? Dr. Baghani, can you?
Yeah, absolutely. Okay. So the first question is asking which of the following is the most important phase of the root canal treatment? Cleaning and shaping is a correct answer. Cleaning, shaping the canal. Cleaning is the removal of the organic debris, and shaping is creating a taper, and each one of those steps assists the success of cleaning and shaping, and therefore the success of the endo treatment. The second question is cleaning. Cleaning involves the removal of all organic substrates of the root canal. Shaping involves creating the canal into a continuous tapered shape. So both of these statements are correct. Cleaning is removal of the organic material, such as bacteria, food debris, and the collagen fibers, and shaping is creating that shape so we could easily obturate with the gutta perca material. Question number 3. Ideally, copious irrigation of canals should occur with what percentage of sodium hypochlorite, and at least how many milliliters of sodium hypochlorite is used per canal after each instrumentation? So the answer is D. 2.5% is the ideal amount, and 30 milliliters is the amounts we use for each canal. Question number 4, all of the below are primary functions of sodium hypochlorite in the irrigation step of cleaning and shaping of the canal except. So the answer is removal of inorganic debris. Removal of organic debris, lubrication, and antimicrobial agent are actually primary functions of sodium hypochlorite. Removal of inorganic debris is actually the primary function of EDTA. Which is a chelating agent, and it removes minerals such as calcium, phosphorus, etc. Carving back is defined as, the answer is B. We'll go one option at a time. Filing and reaming to enlarge the canal sequentially from small to large is actually the sequencing, which we typically do. This option B, the rotational and translational withdrawing motion of a curved file against the dentinal wall is to remove some of the dentinal debris after irrigating and essentially pre-flaring it, and that's what carving back is referring to. The bounce back of a fine file when encountered by resistance or barrier is actually bouncing. And the last one, which is the repeated and reintroduction and reapplication of the previous used smaller files after irrigation, is recapitulation. Question number 6, sodium hypochlorite should be injected rather than ejected into the canals. This is false. Sodium hypochlorite should never be injected. It's often ejected and withdrawn from the canals. We don't want to extrude any excess sodium hypochlorite out of the apical end because it is toxic to the tissues. Apical constriction is the narrowest area of the apical region of the root canal that is commonly located within blank of the radiographic apex. The answer is D. It's located of around 0.5 to 1.5 millimeters of where the radiographic apex is located. Question number 8, the appearance of a fall at the radiographic apex always indicates the presence of that fall at the most apical portion of the roots or the clinical apex. This is false, again, because we could have, sometimes we may have some buccal or lingual curvature of the tip of the roots. So just because it shows radiographically that you're as apically as possible doesn't necessarily mean that you've reached the actual apical aspect of the roots. Question number 9, which of the following is true regarding pre-curving of the files? So the answer for this is E. A and B are both true. Smaller files should be pre-curved closer to the tip of the file, and this is for having a pronounced probe, so we could find better apical patency and locate places we want to be in the canal better. However, larger files should be pre-curved more away from the file because of the strength. The larger it is, the more strength and the more effective it is in cleaning and shaping the larger diameter of the canal. And last question is, the envelope of motion is defined as the up and down stroke push and pull motion for the purpose of. The correct answer is A, establishing apical patency. We do typically do that within 0.5 to 2 millimeters of stroking push and pull motion with some rotation when we're taking it out to get some of the debris out. But this is mainly to establish apical patency, and if we can't really reach the apical ends, we use this method to try to reach the apical ends. And that's it, the questions.
Thank you so much. Guys, do you have any questions? You can type it in the chat. Dr. Lewis is here with us and he can answer any of your questions.
Hi, Dr. Sally.
Thank you so much for joining.
Thank you for the invitation, and congratulations, Dr. Ehsan, on his presentation. Yep.
Do you have any tips from an endodontist?
Well, there's some things that I saw, for example, in the questions that we always wanted to like narrow it down into like one answer, like A, B, or C, or something like that. But for example, the first one, like what is the most important, like when they say access opening or cleaning and shaping and obturation, and definitely endo is a sequence. Like if you don't do a good access opening, you're gonna do procedural errors in your cleaning and shaping, and that will follow also on the obturation. So in terms of disinfection per se, yeah, we want to make sure that we have a good cleaning and shaping, but that's a tricky question because all of them are very important per se as a sequence to do a good treatment. So I'm not very in favor of those kind of like selection that we get to see in the NDBE or things like that, because it sometimes with those answers you don't get to tell the whole story. Regarding the technique, this paper is kind of dated, but it pretty much narrowed down to a lot of the concepts that we're still using. Nowadays, when that paper was published to 2001, if I'm not mistaken, the use of rotary instruments was not as predominant as it is right now. Like right now we see most GPs doing it. 2001, it was not that common to see many GPs using rotary instruments. It was more for the specialists. And now even the alloys have changed a lot. And every time we know more about these infections, because we know that with these molecular cultures, we're more precise about the type of bacteria that's in the canal. We know more now about biofilms. So we know that not only that this bacteria per se, like in a planktonic state, it's also that the biofilm, it's protecting it from all the cleaning and shaping that we're doing. So we're finding out that why our enemy, which is the bacteria, has defenses. Even nowadays, we know that bacteria communicates between them, and they actually pass their genes into other bacteria to become resistant to the calcium hydroxide. So we're seeing that every time we're getting more information, but this lecture was mainly at the beginning about anatomy. And since the first textbooks about anatomy, they were very good. Even nowadays that we have micro CT, which is different from CBCT. CBCT is what we use in patient, like when we're in the office and we refer the patient to get a report. The micro CT, we can only use it in vitro. We can only use it for extracted teeth. The amount of radiation is more. And we get to, and that's the one that's used for like studying the internal anatomy nowadays more precisely. So if we actually see all the lateral canals that we have, all the ramifications, how complicated it is, we actually are working in a very difficult environment to try to achieve this infection, because we're relying on sodium hypochlorite. This question of 30 millimeters in terms of volume, yeah, that's ideally, and 2.5%, it's what we consider right now like the most biological, but at the same time, we're achieving this infection. Most specialists will see that we use higher concentration, like pure bleach, like 5.25%. It's more aggressive, it's more, I have to admit it's less biological compatible, but at the same time, we achieve a faster disinfection and acts, let's say, more aggressively towards the biofilm. Because those studies that promotes more than 2.5 were done on planktonic bacteria. And when I'm saying planktonic bacteria, if you guys kind of remember about microbiology, it's the bacteria in its natural state. It's not submerged in the biofilm, and the biofilm protects it. So in order to have the biofilm being degraded by the sodium hypochlorite, you need a higher concentration. You need agitation inside the canal to disrupt that protection that the biofilm gives to the bacteria. But I don't want to get into a lot of things, so I don't know if people have some questions about it, because what I'm trying to say is like, we're getting to know more now about like microbiology, techniques for disinfection, in what cases we can use this irrigation, what cases we can actually, it's better to medicate, because by the nature of the case, by the anatomy, by the complication of the anatomy, it might be complicated to achieve the disinfection, and that's what we want. We're not going to be able to completely sterilize the canal. That's impossible. But we want to achieve the minimum concentration of bacteria inside the canal that is compatible with healing on the canal. And that's been studied, like what will be kind of like the threshold that we want to at least achieve. It's not something that as clinicians we're going to be able to see, but what we're trying to see if the techniques we're using, it's achieving that. If there's any questions, Dr. Ehsan can answer, or I can answer.
Thank you so much for this very informative few minutes. There was a question, I think, from Dr. George. Let me just bring up the chat. Yeah, so Dr. George is asking, what can you do if the file goes to length, but the GP cone does not go to length with the sealer?
Me or Dr. Ehsan?
I'm sorry?
Is the question to me or Dr. Ehsan?
To you. Dr.
Okay.
Ehsan, just graduated in 2021 from U of T. He's
Okay.
he's our newest associate. So let's
So
not put him
probably
on
he
the
saw me.
spot, please.
Probably he saw me on the floor because for that group I actually did cover the clinic, I think, for 4 months. So, but anyway, for when that happens, like when I do my cleaning and shaping and my cone is not getting all the way to my working length, who hasn't had that before? Like I think everyone, even the father of the doctors, everyone has had that before. So there's things that we can do to try to minimize that, because ideally it's not what we want that actually delay us from our goal, which is like have a preparation in which our cone will go all the way and get seated into that shape that we wanted to give the canal. First is that we have to see that I'm doing my preparation. Sometimes I notice some of the students, for example, when they're working in the clinic, that they're using their files and immediately they reach the working length. If they're using a rotary, they actually stop at that point. They don't let the file work a little bit on the canal. So that helps make sure that we're making that conical preparation on the canal. That's one thing. Second, also, we have to always have patency. Try to make sure that there's no blockage of the canal. We debris, irrigate a lot. Sometimes we do the preparation when we try to put the cone in, some debris might be packed in there and it's not letting my cone go all the way there. Other situation is the type of cone that I'm using too. So if I'm using a rotary file on a system and I'm trying to use like non-standardized cones from a different brand, they might not fit into the canal. That's also one of the reasons that might be also happening. Sometimes when we're having our preparation, sometimes we have to go in manually and get our hand files to make sure that, like I said, we don't have any debris that's blocking my canal, that I haven't lost my working length. Is very important to have a very sound reference point, and have the pliers make sure that before I take that x-ray, my cone is going all the way in there. There are cases in which, for example, if it's not going all the way there, your cone, try to check if a hand file is going all the way there. It should, if the cones and the files are from the same manufacturer, but it's being researched and it's been studied that that the cones, sometimes even within the same manufacturer, they don't actually, they're not precise. So there might be the limitations with that. I find some brands are like better than others for that. Sometimes when we have a curved canal, what happens is that we might end up losing some of the length. And when we're trying to get the cone, we're seeing that we're short and we actually have to end up going back again and then use our files. But before we get our rotary in, make sure that you have your canal patent. Make sure that you can get a hand file to navigate that canal before getting any rotary file in. Something else, if you're preparing your canal's hand file, remember that the taper of the hand file is 02. And the cones has to be either 02, because if you're using 04, 06, because of that taper, the cone will not reach your working depth. I hope I kind of answer that question quickly.
100%. There is another question from Dr. Marwa. She's asking if there is any possibility that lower molars have 2 canals only. I know I've seen it in the clinic, and I'm sure there is a percentage of them. Not sure of the number.
Right now, it doesn't come quickly into my mind, but it's in the low numbers. It can be on the 20s, 20-something%, but it usually can be on the third molars, can be on second molars. Also, when we see the anatomy, we might think of that. But besides that, because right now we have, like in some ethnics that it be more prevalent than others, we definitely might be really close to each other. We might think it's only one, and actually they're completely separate ones. I would say in cases like that, explore very well your initial x-ray. And when you find one canal, if you cannot get the other canal, you always prep those canals and take an angle x-ray. That will tell you if that cone or file is in the center of the canal, then you have in that route only one canal. If you see that it goes just more distal, and you do have room for that in that angle x-ray, that tells us another canal. Also, CBCT nowadays give us information about that. And clinically, when we're doing an access opening, and we usually try when we're doing the access opening, go for to look the largest canal. Once you get that, then you start removing more of the roof to try to look for the more difficult ones. If you see in the floor of the pole chamber one large distal canal in the lower molars that specifically we're talking about, try to look up the lines, the dark lines that we see on the floor, and try to see if they go straight into what would be mesial. If you see that you have a very natural large canal in mesial and a very natural large canal in distal, that might be a sign that you only have two. But I will always prefer having after preparation, either with a cone or a file in an angle way, if we don't have a CBCT scan available at that moment.
That does make sense. Another question from Dr. Sharija. She's asking, how would you trough mid-mesial other than ultrasonics? I'm not sure I understand the question.
I
But
think they're asking about the canal that is in between the mesial buccal and mesial legal, what we call the mid-mesial, like a third canal in the mesial root. Is that what the question is about?
Dr. Shrija, you can unmute yourself to confirm. Yeah, she said yes.
Yeah, she's referring to that, yes. There are cases in which we have that. Usually to try to find that canal ultrasonic and magnification, it's the key to actually see. Use a very sharp DG16 endodontic explorer to try to make sure that we are finding a canal or not creating one, because that can happen too. Sometimes troughing with ultrasonic tip is the best way. If we don't have that, I will say use long shank, low birds, and to try to use magnification that you're seeing specifically where you're cutting. After you're removing from those two canals, make sure that you're using the explorer to see if you actually have one canal there. And if you do, use a lot of lubrication. Use a number 2106 or 08 file at that point to see if you can get it in. If you are getting in, I would say once you're penetrating 2, 3, or 4 millimeters on it, use an apex locator to actually see if you are within the canal and you're not, like I say, in perforation.
Perfect. Thank you.